thank you everyone here. I like very much being with you again. This is my disclosure, minimally involving this presentation, that is the Lima design. And the topic is the evolution of reverse shoulder arthroplasty. Where are we in 2024? I must give credit to my excellent PhD that is working with me now. And let's start with the evolution. Of course, we know all this picture with this evolution of the human being, like a monkey, then from 4 legs, then 2 legs, and then adapting the shoulder, and then more erectus, Neanderthalis, and then sapiens. This is the normal evolution. So if we go to this evolution concept from Darwin, well, he said that the theory of biological evolution by natural selection happens, and the evolution of the species occurs as a result of chances and necessity. Remember these 2 words, chances and necessity. This will influence also the evolution of our reverse shoulder arthroplasty. Because even in nature, in species that are random natural mutations at the environment, saves the suitable ones and eliminates the others, mainly through the struggle of life. So survivorship is related to this kind of adaptability. The history of the recent, let's say, reverse shoulder arthroplasty is starting roughly in the 70s. And this is a paper from Charlie Neer, historical, describing, of course, the calf tear arthropathy. And he was reporting, this is very early 80s, that the experience in total shoulder replacement in these cases with calf tear arthropathy is a limited goal target, and most of the patients, few patients, were not happy. The experience started exactly in those years, and historically, these are rare pictures, some anatomic, between brackets, fixed fulcrum system, because some surgeons were trying to get it, but unfortunately, they were failing very, very much. It was keeping a lateral center of rotation and still the ball of the humerus on the humerus, so they were anatomic somehow with this fixed fulcrum, but the glenoid bone stock and fixation was not holding enough, so this was killing these pieces. It wasn't surviving. So other surgeons in the same years tried the early reverse fixed fulcrum design systems. But again, since the center of rotation and the lever arm was too high for the tools available at that time, the glenoid fixation and the component breakage killed these pieces too. So it seems to be a failure. And the same happened with Charlie, of course a genius in his field, and very few of you remember this Mark 1, 2, and 3 prosthesis. You see that the Mark 1 and the Mark 3 in this case had significant differences because Charlie was trying to solve the problem of the mobilization and the mobility of the arm. And in the Mark 3, this is the bottom right picture, has even a turning stem. So it was a dual mobility implant at that time. Still, it was failing. And Charlie abandoned this in 1974 because of dislocation and scapular fixation was not strong enough, killing also this species. Finally, 1985, we moved, I should say that Paul Grammont moved into a semi-constrained reverse design, the so-called trumpet. Medinov was the producer at the beginning, not Tournier, and a little small company. And he was reporting the early cases, and he was blamed like a crazy boy doing this kind of surgery on the patient. And it happens quite often. Crazy ideas at the beginning are not very well accepted. Anyways, he developed this revolution. The prosthesis should be, in this case, inherently stable. The weight-bearing part must be convex, the reverse. The center of the sphere must be at or within the glenoid neck. The center of rotation must be medialized and distalized, and the glenoid component is 1/3 of a sphere at the beginning, with a large diameter, 36 and 44, and no neck. And the humeral component, like a small cap, oriented with a non-anatomic inclination, 155. This is the classic Grammont design that is born, and it was a success of these pieces. And it was spreading all around the world. really all around the world, a great success. So we are moving in the evolution of the system from the Australopithecus reverse, the reverse habilis, Charlie Neer, and now the reverse erectus. Now we have the Paul Grammont design. But still, we have a long way to go. We are not very happy, totally happy. We are much happier than before, but not totally happy. So, because we had some necessity. So chances by nature, necessity by the necessity that we have in the daily life. And the drawbacks of this design were unsatisfactory rotation, active and passive, we all know about it, especially external rotation, abduction, external rotation. Elevation was good, so we were not very happy with this, and we know that. Then instability, especially at the beginning, not anymore now, but at the beginning, every one of us was experiencing some instability after a reverse implant. So this was another necessity of the evolution of the species. Another necessity of the evolution of the species was the notching and the polywear that was leading to a disease of the bone and the notching, and then potentially a failure of the glenoid component. Another one, necessity, it is also somehow cosmesis, because the profile of the deltoid is changing, and some ladies, they didn't accept this very nicely. Not a major necessity, but still a necessity of the evolution. This is why, entering the new millennium, this is Mark Frankel, we started thinking the lateralization of the glenoid reverse design. But the early design was failing quite a lot because of the increase of the shearing force over the glenoid, and Mark was reporting 12% of glenoid failure, and this was an initial glenoid fixation complication. However, in the evolution, it changed a little bit the design with a 4.5 millimeter peripheral locking screws, and then this was leading to a stronger fixation of the glenoid component lateralized and leading to the success of this species. And on the same road, Pascal described a similar way to lateralize the center of rotation, keeping this inside the bony aspect, and so he developed what is the bony bio-RSI that many of us have experienced with good results, with minimal changes in the base plate, and it was also a very good success of the species. At the end, this principle of lateralization of the glenoid was so well accepted that now we have available in the shelf of the supermarket of our implants in many different designs. The 2/3 of a sphere, the DJO, the lateralized glenosphere, Stryker, Tournier, Zimmer, Biomet, the glenosphere over the base plate, and you see here the list, and the increased glenosphere diameter, because this was really helping a better success, responding to the necessity and not only to the chances. Then we started thinking that we needed a better aspect also on the glenoid side. So we started thinking about an increased offset that is a more appropriate definition other than lateralized humerus reverse design. So starting decreasing the humeral neck angle, you see the list of the many products on the market with this, and the onset humeral tray, and again the list of it. And it was even increasing the success of this species, responding to the necessity that I was describing before. So now, we are reaching a good result for the reverse erectus system that is improving more and more, going to the reverse lateralized. Still, we are the Homo sapiens, and we want to improve it more and more. And all these products on the market, first of all, we need to know them. This is something that not all of us done, because each of these designs has some peculiarities that we should know when we use those with some little differences. So I spent just a few seconds about this, because any design may be differentiated according to the glenosphere and the humeral side, with the medialized glenoid, with the medialized humerus, lateralized glenoid, or lateralized humerus. And the center of rotation is not medialized, it is medialized when you are not reaching 5 millimeters or less, And the same on the humerus, you may have an offset of 15 or greater than 15. So every single design has differences, and you should know this very clearly when you make your implant. This is a beautiful study from Vertel, reporting starting as a standard reference, the delta 3, that classic Ramon design, the glenoid lateralization, where you have less than 5 millimeters or more than 5. When you have a humeral lateralization, under 5 millimeters or between 5 and 9 and more than 10, and the global implant lateralization under 5, 5 to 10, 10 to 15, 15, 20, and more than 20 millimeters. So you should know when you make your implant, it is not a random implant. You should know what you are implanting. You should study your implant. And this is a provocative paper from Gilvage. It was really a necessity, everything I described so far. This is a paper where he is reporting a long-term follow-up of the typical classical Grammont, and it is a recent paper. And you see that the results, the numbers you see in the right column, that basically you don't have any declining of the function, and the clinical and functional results are still good even with the classical design. So this is just to think about. Staying on the necessity is the glenoid. We were discussing this so much. It is true for the anatomic, even more true for the reverse. So on the glenoid side, we found many solutions, including a very well-shaped bone insert or design with a stepped augmented glenoid with different angles, different size, and so on and so on. So you can choose the clothes that you like the most according to the needs of the patient and your surgeon preferences to answer this necessity. Another necessity is notching. We want to avoid it. And lateralization was a good result for the mechanical thing, but still we have the biological, that is the scapular notching related to the poly wear. It is different. You have a mechanical notching, you have a biological notching. And still here we are working. And this is some ideas that are available in the market, like inverting the bearing reverse shoulder arthroplasty, having the poly on the glenoid side and the metal part on the humeral side. And we demonstrated, we published a few papers on it, that it is providing a good, stable result even in the long term. This paper is now with a minimum follow-up of 10 years with the results. And it is a reliable option for the polyethylene wear disease. Whatever, the worldwide reverse mania is exploding. You see here the famous Australian orthopedic registry, and you see here the report for the prosthesis in the shoulder. The blue line is reverse from 2010 or so. It is going up, and the anatomical is going severely down. However, the most you use a tool, the most you want to ask the tool providing answers to your issues. So we started thinking about other aspects of our reverse prosthesis implant. That includes fractures, the stress shielding with our implant, the long-term loosening, the anatomy in fracture sequelae, and the future revision. And most of all, younger patients are receiving shoulder arthroplasty, then bone-preserving humeral solution may help for the future. So we started working on a shorter stem. Just to speak the same language, this is a classification coming from Patrick Denard. What is a component stemless when the length of the stem is under 50 millimeters, short is 50 to 100, standard is 100, 150, and extended over 15. And now we have many short stem reverse design available, and they are under observation. Some designs are changing already, curved, straightforward, whatever, because we are noticing some issue. It is a short life, only 1 decade or so, so we are still surviving, but for the evolution of the species, under observation, let's say. And the same is true for the stemless, so removing completely the stem and having this specific design. You have only these three for reverse available in the market, and you notice that the new metal, the trabecular metal, titanium and so on, are helping very much. So tribology is also supporting the evolution, But still be cautious. Time will test these pieces. We are waiting for the results. Then, reverse sapiens. We are in the modern era of technology. The last step, where are we now? Last but not least, planning and surgery technologies. They were little hidden by previous presentation. We have the patient-specific instrumentation, you have the planning system, we have the navigation, augmented reality, a lot of beautiful toys. We like the images, but still, even my friend George was mentioning this. I'm not doing this in every single case. Honestly, I prohibited my fellows, my residents, to do every single case with assistance. Otherwise, they will never learn how to manage. And also because there are numbers behind that. This is a paper, 2022, comparing the differences from Osiris evaluation and the major three most famous, let's say, systems for planning, the VIP, Blueprint, and comparing the data. And you see that this system are providing numbers and results that are statistically different from the Osiris system. So let's say that commercial 3D dimensional imaging programs are not created equal. So the machine is doing what we teach the machine to do. And this is something, of course, understandable, but we need to keep in mind in our head. And this is a paper that is now published exactly last year, and they told me that it was very much read. What we did, I took my residents with the Blueprint, could be anything else, version 2018 and Blueprint 2020. And I told the residents, now you study the same shoulder and you bring me the results. And we found significant different inclination and data. This is not meaning to me that we should not rely on the system, but we should not rely like blind people, because the machine is taking care of the numbers that we input. And sometimes we don't know exactly the number who are correct, and they are changing and evolving along with the system design. And so we need to carefully and critically evaluate the data acquired with automatic software. So as a conclusion, Daniel O'Neill, I hope my Greek translation was good enough. Nothing comes from nothing, and everything is evolving. Somebody did something before us. What we are doing today is the work they did before us, but still we need to give a contribution to it and accept that the itinerary is never ending. But my recommendation that we should know the past, we should question the present, this is why we are here today, and project the future. And never transform the Homo sapiens in a machine, because this is an involution. Let's keep the brain working and keep the Homo cogitans, the thinking man, when we do our job. Thank you very much.
Alex, thank you very much for this very nice lecture. I want a comment from you. Looking in reverse, the last 30 years, we know that the complications decreased. We know that the performance of reverse arthroplasty has evolved because all these biomechanical data are improved, all the reverse. So my question to you is, when you check your patients with reverse, what do you think we should evolve more? We should evolve like flexion, stability, rotation? What do you think we're missing and we have to work on the future?
It is a never-ending answer, let's say, because, again, the patient coming to us for a potential indication for a reverse prosthesis are complaining about pain, function, strength, quality of life, again, as I said yesterday about the rotator cuff. And we are not always providing everything together. For many reasons. Again, I don't want to steal too much time. I mean, the position of the scapula, Offer mentioned this. This is so important that we do not consider the mobility of the system, that is not only the glenohumeral joint with the fixed scapula, it is a system that is moving. So the posture may be influencing this, or the remnant part of the cuff, or other things that we cannot completely know. What I believe, that I didn't mention this is a concept that I strongly believe in. It is the 3D printing and the custom-made design that is now not accessible to everyone because of terms of cost. But for instance, in my university, we now developed the Innovation Center, and I'm participating into this project. And we are now making our own guides. It is €5 with your 3D printer. And very soon, not tomorrow, but soon, we will be certified by the Ministry of Health to make a 3D printing, let's assume, a fracture of the clavicle. We make the CT scan, 3D printing, and we can develop, and already approved for implant, develop the plate. As soon as this will become, not tomorrow again, more affordable in terms of money, most of the dedicated system, adaptability, and so on, will become, not for my generation, but for the future generation, a custom-made design. So if you ask me about the future, not where we are today, it is this: to develop affordable systems that may lead to a very customized design, at least in the more complex case, but not, you know my history, you probably listened to this, the green and yellow and red light that I do for my fellows. Tell me if I'm too long, Manus. And I have 3 levels. Green light, because my fellows, they do the MPR, they evaluate that glenoid and so on. If it is entering a B1 or easy case, it is no assistance. Just go straight with the system that you are implanting. Otherwise, they will never learn how to operate and face an issue. Then you go to the B3 something, and then you need some assistance, and it is the yellow light, and you do a planning, and then you go to the red light, where it is so complicated, and you need a custom one. Probably the red and yellow line one day will be all custom-made. This is my opinion.
Okay, if there is a last comment, please, Manos, and this is the last question. We have run out of time.
Well, it's not a question. It's a comment about Alex. We met something like 25 years ago. At that time, I met him in San Diego. I was a timid young doctor trying to understand shoulder. And I went near Alex and said to him shyly, "Hello, I'm Manos Antonianakis. I'm coming from Greece. Could I come to Milan?" But Alex was more timid than me and said to me, "Wherever you like, you can come." And so shoulder experts now were 2 hours away from Athens. And so I went many times, and I still consider you my first mentor in shoulder arthroscopy. And after that, when we start organizing the first course in Athens, the first shoulder course, arthroscopic shoulder course, Alex was here. And then shoulder expertise was in Athens, not just 2 hours from Athens. And this is not only for me. Many, many doctors, Manos included, and many others here, consider Alex the mentor and the person who brought shoulder surgery, shoulder arthroscopy in Greece. Thank you, Alex. Thank you for what you have done till now and what you are continuing doing. In my lecture, I am going to say that you must not trust blindly these instruments because they include human error, which is not obvious when you see the system. And suddenly I hear you again talking about this. And I say, oh, he was my mentor. He is continuing to be my mentor. Thank you again for being with me.
Thank you for your words. Thank you. Thank you.